Apart from pragmatics, the other bucket of SLP profession is voice. So this is easier to explain or to understand. There are gender roles in voice. In some cultures, you would actually hear that a lot of the girls in the same age groups would actually use the same voice, regardless of their birth voice. It could be a entertainment business, a media influence type thing, or it could just be a social gender expectation type thing. So they tend to assimilate to each other in terms of the voice that they use in their own gender. And the age also plays a role. So for someone who is assumed to be more socially or corporate powerful, their voice are expected to be at a certain level of depth, right? So you don't expect me to talk about talk to you like this in a video, versus if I were to use a deeper voice, to certain people, they would stereotype it as more credible. So that goes with occupations as well. So there are occupations where the voice need to be a certain projection, or their articulation also are expected to be different. One very stereotypical example could be the radio announcer or the sports narrator, right, where they actually need to fall under a certain expectation or box on how they use their own voices. The other population that is actually a specific population to treat is the transgender population, where how a male voice, originally male voice, needs to be treated to show more feministic qualities. And for SLPs to be treating that population, we don't only need to respect the patient's or the client's need to transition their voice or transform their voice. We also need to respect their need for additional privacy. So they may actually need to be entering your clinic from a different door and waiting in a different waiting room. And they may actually not answer your calls in public, but would actually message you back, just because they are less comfortable with their voice, with their altered, in contrast with their altered body when they're, showing themselves in public. So we need to respect that as well. The second last bucket of service that we do is cognition. So we need to understand the diversity in levels of cognition across different cultural populations. People come from different places of the world. They also come from different times of the world. We have to understand that different times of the world in different places are very different from the luxury of peace that we are enjoying now while watching this video. Some people come from war-torn countries. Some people came from countries where there was a cultural revolution and a lack of access to school and education when they were young and in need for education. So that level of education or literacy actually affects them a lot in adulthood when we're assessing them for cognition. For someone who was illiterate as a baseline, and if we use something like a Western aphasia, a battery, you need to be reading out certain things and understanding complex sentences like the quick brown fox jumps over the lazy dog. That may actually not be possible for someone who came from history such as the ones that I described just now. So it may be we may actually choose to not score that wrong because, or we need to score the WOB with sensitivity, because that actually may not be the baseline of that person. So they might have taken a few years of school, but after 60 years of life, they have forgotten a lot about reading and writing because they've never had the opportunity to use that much. Or, they mastered English as their second language, but after a stroke, they lose their subsequently languages first and regress a lot in their primary language. So the fact that they were bilingual before the stroke and does not mean that you should score them the same way after the stroke, because their baselines were actually very different. The level of ability in different languages may be actually very different. And cultural norms and social norms and values are actually very different as well, I find. There are cultures where the family plays a very critical role. So, when talking about cognition and when your client is deficient in cognition, the family would answer a lot of questions for you. So that the family interview becomes a very big part of your results. But family interviews would be, partially based on the pre-morbid behavior and partially based on the post-morbid behavior. We have to be cognizant of the fact that family may actually sometimes not understand very clearly the differences before and after. And because they have been with the patient for so long, there may be assumptions and projections made on what they think the patient is asking for or responding to, which actually may not be accurate. One major challenge that I see as SLP serving a ethnic immigrant population in North America is the varying ability of self-reflection and self-evaluation. I find that level of schooling and cultural norms actually play a very big role in someone's ability to actually self-reflect. It is not because it may not be true that their schools don't encourage the fact that everyone needs to self-reflect, but the way that that skill was taught was probably very different than how in North America that skill was taught. So I don't have the answer to that question, but I can assure you that based on my experience treating the bulk of this population here in North America, the ability for your patients to self-reflect was hard before, so pre-morbid as hard as it is post-morbid. Parental models also play a role. So if their parents came from a country where the education system is very different, now the kid is in a family in North America in an education system where you and I both understand very well. The kid is actually exposed to two very different and very contrasting education system and value system, and their behavior may be a mixture of these two models. So they, in certain sense, they will show varying behavior, and that may not be a red flag. It may also just be a result of parental models. The last bucket of services that we provide is swallowing. So, swallowing safety, we're very attuned to, and we understand very well the differences in diet consistency. But how do we describe that to our clients? How do we make sure that what we say is very well applied in the client's life? So when you say, on your mashed potato, put some cream to add moisture to grains and starch and soft solids, what does that mean to someone who actually never eats mashed potato, and for someone who actually, cream is not part of their diet? So you need to understand the diets of your patients, not only from a clinical dietary restriction point of view, such as low sugar for diabetics and keto diets for certain people with seizures, but also their cultural diets. So what is the starch that they eat? If it's not potatoes in the Western society, it could be rice, it could be non-bread, it could be bread, it could be noodles. Even in the Chinese diets itself, Northern Chinese diets and Southern Chinese diets can actually be very different. There are also cultural and religious dietary restrictions or preferences, so kosher or the lack of spice use in certain Buddhist populations is not only just, they need to be vegetarian. In stricter Buddhist protocols, actually spices are actually also not allowed. The use of sauce and moisture in different cultures are actually also very different. So, in the Western society or in North America, you may think of, a baked potato with sour cream or a mashed potato with gravy. You can think of, the fact that can you actually eat your mashed potato without gravy, or can you eat your pancakes without syrup? That's the kind of distinction that we have to be aware of. So some cultures take the sauce as or what we think as sauce as the main. So let's say the Indian diet, curry. So it is not curry chicken as in the chicken is the main, but the curry dish itself is the main. So it's chicken curry, vegetable curry. The sauce itself is the main. So this would be a problem for people who need to avoid mixed consistency diet. So in the curry, there would be grains, it would be vegetables, or it could be proteins. So how do we tell them to avoid mixed consistencies? You may think of it as, vegetable soup, so you have the liquid and you drink the liquid, but, sift out the veggies. What if the vegetable soup is not what they eat in their whole entire life, right? So you need to understand that their liquid could be the curry. Their soup may be very different. Now, on the topic of soup, the Western society thinks of soup as in the liquid itself and anything within it. And when you say soup, you may say you drink the soup. You may say you eat the soup, because the soup to you could be an entree. In most East Asian cultures, the soup itself actually is not an entree. When the East Asian cultures refer to soup, they could be making a very big broth. There could be a lot of proteins, grains, and vegetables within the soup, just like the Western soups. But when they refer to the soup, they're actually referring to the liquid itself. And they certainly don't just drink the soup as an entree or as the meal alone. The soup may be to start or to finish off a meal, but never the whole meal. And many a times they actually drink the liquid and treat the solids very differently. So when you say soup to them, it's actually not the whole meal. So when you're prescribing your diet alterations or modifications, please be cognizant that if you're referring to soup, you make sure you refer to the other solid entrees as well. And there are some cultures where the starch is a staple, and there are some cultures where starch is used very differently. Such as there was one time, one of my Indian friends came to Toronto to visit me, and they asked to enjoy the most authentic Chinese food. So I showed them to a place, sort of fine dining Chinese food, and then they complained about, that waiter didn't tell me that dish that I ordered didn't have a lot of sauce. So needlessly, we ordered the rice. That shows you there are very different concepts between the use of grains or starch across just the two Asian cultures, Indian and Chinese. So and for Southern Chinese, at a typical meal, there is rice. There is the bowl of rice as a staple, regardless of what you eat, regardless of whether there is sauce. But for my friend who came from Indian culture, she was thinking, well, I would only have that grain or the starch if there was enough moisture to go with it. I expected your dishes to have a lot of moisture, but there wasn't enough sauce to go with the rice, so it was a waste. It's actually, even within the same continents and very close by cultures, the concepts could be very different. So when you say put a lot of moisture on your starch or on your semi-dry solids or dental soft solids to your patients, you actually need to understand what solids they're eating. So if you're referring to their starch, for the Asian cultures, whether it is a naan bread or the dumpling or the noodles or the rice, they actually may not put things on top of it. They may actually use it to eat with another dish that may or may not have sauce. So how you design their own meals for them is your ability to get creative. If you don't apply your own science to their daily life, the compliance level is likely going to be very low, because your patient is not going to understand what you're talking about, nor will their food preparers understand what you're talking about. You also need to understand the differences in the use of spice and consistencies, right? So there are some diets where the use of spice is very heavy, and for some of your populations where, if there was a use of blood thinners in their medication list, or they're preparing for surgery, they need to be off spice. So when you're trying to say to them, cut off your spice for 2 weeks now, for someone like me who takes no spice at all, for me, ground pepper is too spicy, right? So I understand that as in anything that tastes or feel mildly heated. For someone who comes from cultures where spice is a staple, they may not think of cumin, ginger, black pepper, or chili flakes as spice. So you actually need to be very specific with them what parts of their diets they need to cut out, because their baseline is very different from your baseline. And for maximal level of compliance, you need to understand who is actually preparing the food for them. Is the patient itself? For aphasic patients, most likely not, because of their post-stroke and the very high probability of mobility restrictions. So would it be their wife? Would it be their sons and daughters? Would it be their parents? Would it be their caregivers or the PSWs, which change, or CNAs, which change every day? They come to your house, or they come to your hospital bed, there'll be a different one preparing a meal for them every day. So we need to make sure whoever is taking care of them understands how they can or cannot prepare certain foods, and how they can or cannot feed certain foods. After understanding all 6 levels or 6 buckets of services that SLPs provide, the one last question that SLPs in the multicultural population often encounter is, should I introduce bilingual education to my kid? Is it what's causing him to be delayed in languages, especially in kids with special needs? Right? So we need to understand the pros and cons of bilingual or multilingual education first. So for the ethnic population in North America, these families may want to preserve their home language and cultural values with their children. So the pros for bilingual education would be to, then there is better ways for the kid to scaffold for future learning, because there is more than one system of building blocks. And they may get better career prospects because that opens their ability up to different populations within the country. Now the cons would be, and these may be short-term cons, or these may be long-term cons, depending on the ability of the specific kid we're talking about. So language development process may actually take longer. So instead of a steady curve that straight goes up, it may be a longer plateau time before a huge boom. And during that time, parents may think there is a delay, or health practitioners may flag the kid for an SLP developmental language assessment. And another con would be the fact that it is less suitable for kids who have learning disabilities or ASD. And another thing that we need to be cognizant of is the fact that parents with foreign language accents may actually transfer that to the child. So we may have children in the school system that speaks 90% fluent English without a hitch, but you would see them going F for the sound well beyond age 9. So that's after the phonological development. They're still doing the F for the TH. It may actually not be a developmental issue that warrants a regime or articulation therapy. It may be a cultural difference. So articulation therapy, if you choose to implement that, would be very different in terms of the reason, and maybe different in terms of the treatment plan. Lastly, in terms of understanding the process of bilingual development, initially the child would use the home language for a brief period of time. That's because that's the first language that they know. And then going to school, the child learns a different language, most likely English or Spanish in America or French in Canada, right? And then there is a clash between the home language and the new official language that is being taught to the child. So the child goes into a silent or nonverbal period for a period of time from weeks to months. It depends on how fast the child can actually process the distinction and be able to express using them. So this is a period when the child is trying to build up the understanding of the different languages and the nonverbal gestures or communication practices that come with the different codes. So afterwards, the child may actually begin showing you imitation of short sentences or phrases, or they may use canned phrases in a very repetitive way, sort of, carrier phrase or formulaic like. And then eventually, this child would be able to, after a code switching period where you see, child using the same different languages in the same sentence, eventually the child would actually, break away from the formula or the carrier phrase or the code switching behavior into using specific language patterns and nonverbal patterns at specific times. In other words, the child would know when to use what language and how. For example, the child would use strictly English and North American mainstream quote-unquote manners with the teachers. And at home with grandpa, child would use their home language and their own sets of nonverbal cues. This is when the child truly masters when to use what. That's all I have to introduce diversity in the SLP profession for all of you. Hope you enjoyed the video. Thanks for watching.